Good afternoon, EQIP pioneers. Thank you for joining us on this live webinar. My name is Melanie David-Fevick, and I'm the project coordinator for Epilepsy 12. Today, our two QI presenters, Pat O'Connor and Mirik Skypak, will provide you with training on measuring change in QI using data. A link to the recording of the webinar will be circulated to all team members and made available on the QI Central website. If you have any questions about the training, please email the team via the EQIP email address. Thanks again for joining us. Over to you, Pat.
Pat O'Connor here. And myself and Mirik will be, as Mel pointed out, going through how you can measure change in your QI project as part of the EQIP programme using data, and lots of different kinds of data that you have at your fingertips within your service. So we're really looking at that measuring change. Our discussions this afternoon, and there will be an opportunity for individuals and teams to ask questions, is really trying to get you to think about how to make the measurement systems that you're using meaningful for your projects, how to select your measures and what kind of data you might be collecting, and presenting data and stories, not only using charts, but really using the narrative and patient feedback that many projects are concentrating on. And the most important thing you'll remember from when we came together as a collaborative for the first time is that improvement data is about usefulness. How is it helping you and the system and the staff, the teams, the patients and families learn to change the system and improve it for those not only that provide the service, but for those in receipt of that service. So we're seeking usefulness and not perfection. It doesn't need to be every single part of the service that's measured. And you'll also recall that we posed a number of tools and shared many of them with you. And as part of your project, you have, while you've been on the calls, really talking about the aim of that improvement system, that one sentence that said, how good by when? And you're now starting to think about how your data and measures relate to that. How can you demonstrate the changes you're making by monitoring and measuring what's going on within the system? Some of you have had some discussions already about what you should measure and how you can measure different aspects of your quality improvement work. And both Mirik and I are going to talk this afternoon about the many different ways. Not only can you capture data, it's not just about numbers and charts, but it's also about the stories that both the staff and your teams and patients and families tell you. And then thinking about how you can present that data as we move forward in the EQIP journey. So on this slide, I've tried to recap some of the aims, and they might look a little bit like one of the aims that you have in your project to reduce the patient journey, let's say in Clinic X, by 50% by May 2020. Remember, an aim statement is usually one sentence. It has some kind of improvement percentage, and possibly talk about the date. So we put May 2020 at the moment. I'm sure you're aware of all the goings on in the world today, that that's going to be postponed until we can get together given current circumstance. So the aim talks about how good by when, and there should be an outcome in there. It's not just about getting more patients, for example, to engage. It's about what you do with that engagement. And is that something that happens continuously and not just a one-off survey, for example? Here's just a little reminder of what your driver diagram might look like. There's a link in one of the last slides to actually help you if you want to rebadge your driver diagram or you want to use a template. There's a link to the QI tools that were mentioned when we came together at the collaborative, and you can use that to demonstrate your driver diagram. So your aim is on the left-hand side. You have primary drivers, the things that will crash and burn your system, and secondary drivers, and then the change elements, the ideas on the far right side, the little ideas, the little tests you're doing to try and make a difference in your service. We've been using the model for improvement from Langley, Provost and others, where not only the PDSA cycle, which is the testing method, But the aim, measures and changes are all part of that. Is the team clear what you're trying to accomplish? How you know a change is an improvement is the whole focus of our discussions today. And what changes can we make are these little tests that we do. We make a plan, we do that plan, we study it, and then we reflect on what's been going on before. And you'll be very familiar with this cycle when you've been doing audit work over many years. It's exactly the same process. This is not a new model, it's just demonstrated in a different way. And an example in the EQIP programme is outcome, process and balancing measures. And you'll have that in there. You'll have data and stories and pictures of what's happening in your service. You may have outcome measures. So this is the voice of the patient, and that might have a direct link to your aim. For example, if you're reducing waiting time at the clinic, you might be asking patients how they feel about that. Was that helpful? Or did they feel rushed? There may be a negative impact in what you're trying to do. But you would be hoping in there that it's going to show some kind of patient satisfaction, that they've not had to wait too long. Perhaps your complaints would go down because the patients will be happier, that they're not waiting around for too long in the clinic or in the community system that they're engaging in. And then that's from the voice of the patient's perspective. Process measures are everywhere in our service, and that might be a measure to look at the number of patients seen, the reduction of the waiting list, really looking at individual components of the service you're trying to provide. And there are many examples of this right across the EQIP collaborative. And then there might be balancing measures, which is about the whole service. And patients might not be interested in some of the measures we have in here, but this is from the service from a different direction, different dimensions. And it might be appointment allocations changed, it might be a reduction in referral time or an increase in referral time in relation to different components of the service, depending on what your goal is, and a reduced overall appointment journey. All of these are reflections of the many discussions we've had on our calls in the EQIP collaborative. So we might be looking at efficiencies within the service, and there are examples of that. So this is just one slide to really think about the ways in which you can frame up the things that you're doing already. And one of the most important things is to make the data collection system easy to use. It has to be easy to do. We don't want a complicated an hour and a half for the staff to actually collect the data. It needs to be designed by the frontline and really being used. The data has to be of some value to the staff who's collecting that. And certainly if you're using feedback, feeding it back to the patients and families that have taken time to tell you how they feel about the service, and actually telling them what you've changed as a result of their efforts to engage with you, and putting together a plan. No, really writing down which measures that you're going to focus on, how that's actually helping the team and families, so that you can share that when we come together to celebrate success of this collaborative. Once you get started on your tests of change and you're started to collect your data, you may see fluctuations. So if different staff are on duty, different things happen, or if a different doctor's at the clinic goes a bit slower or faster, or the patients seem much more satisfied. So you want to look at the reliability of that change that you've made. And one way you can do that is simply ask 5 people and record what you get. And really involve those around you in your service, because you'll know that asking people to change the way they do things can be quite difficult in a service. We don't like change. We like to say that we're all improvers and we would welcome different techniques and different approaches to care. But when it actually involves us as individuals, it can be quite difficult to get people to change their practice in a different way. So really involve people, because those who engage more actually are more enthusiastic about the changes that they can make, because they do feel involved in what you're trying to do. It's very important. There's a huge social aspect to change that we've touched upon in the collaborative, and that we will be talking about more and more as we go through the remainder of the calls before the celebration event. So get your frontline staff to verify and validate the data. Think about what the service is learning from the data, because that's the way people will continue to engage. If they see that their suggestions and ideas are taken on board and that they're part of that change, it's much more likely to stick or become a reliable system. And remember your theories and predictions when you're doing your tests of change. So keep it simple, link it to the goals and direct patient care, and get everyone in the design and collection of the data. So don't hide away in a little room and design a forum that maybe the folks in the clinic can't really use or don't understand the value of that process. Make the process visible, so if the patients and families and staff give you an idea of how things can change, remember to take photographs. So simply showing before and after photographs is a great example of how your improvement project has made a difference. And it's really good to share that with patients, families and staff to see if they think it's improved and whether these changes are actually embedded in the system and you're able to hold the gains. Very easy way of collecting data is this slide here, pen and a piece of paper. If you're collecting numerical data and you want to measure the length of the patient journey or the waiting time in the clinic, then you can easily do that in numbers of minutes on a simple chart like this. You don't need a software system. You can put the numbers up the y-axis and then the time the patient waited or the day of the week the clinic was. You could put numbers and hours up here and days of the week in particular clinics along the bottom. Time always goes along the bottom on a chart. One of the ways that we would encourage you to use graphs and not just a table is by simply looking at this information here. You can see that in July, the piece of improvement work was 90%, and in July in the table you can see 68. But if you have to read along there, you have to scan along, and I'm sure you're at many meetings when this happens, and you've got to scan along the huge Excel spreadsheet and see where the change has happened. Whereas if you plot it on a chart, and a simple run chart like this would do, it doesn't have to be electronic like this one, it can be simply a pen and piece of paper, and you can look at what happens over time. You can put the goal line in, and I'm going to give you an example of what that looks like, perhaps in our EQIP journey. So here's a chart here using quantitative data to measure the patient's journey. So we want to measure it in hours. It's actually a long time at this clinic, and I've heard many of these conversations when we've had our check-in calls every month, where people are waiting a very long time to see all the different components of the service. So here's a hypothetical example of that improvement work. So we started in October, November. In December, we tried to do between December and January, because it's Christmas time, it's difficult to change. So we changed appointment times at this clinic in early January. And we saw a bit of a difference there for a few weeks, and then we rearranged the clinics. We brought different patients in cohorts to different places. And then between March and April, we ran joint clinics with the nurses and the doctors. And you can see in this example that over time, the first half of the chart from December to March looks very different from the last half of the chart between April and June. And we would hope that your improvement journey looks identical to this. So there are fluctuations, there are variations in the data, we're trying to make changes, we're recording in narrative words on the chart the PDSAs that we're putting in place in this clinic. And we can see in June that there's been a slight increase, and as a team we would want to look at that. But you could apply, if you wanted, some run chart rules to this, and you would see 3 very different phases of improvement, from December to February, from February to April, and from April to June. So it's a fantastic way to record numbers in data when you're using numbers or measuring numbers. But not everyone will have an improvement project with numbers. Many people are collecting patient and family feedback data. So I've tried to give an example in this slide here of how you can do that. You can gather the patient's idea, I want something to do while I'm waiting at the clinic, and then you could introduce games and activities in the waiting area. Want to see the doctor and nurse at the same time, and the example I've just given is you could realign the clinics together for joint appointments. And I'm not going to read every one of these, but you could take pictures, or you could put a wee cartoon against the patient and family. You could of course anonymise that, and then tell us what the patient suggested. What did the children, what did the families want of the service you're providing? And what changes, what did you test as part of that process? And what changes did you make? So you can doodle it, you can take a picture, you can do all sorts of things in the ways that you can share with everyone in this collaborative the changes that you've made and the impact that that's making to your service. And what you've learned along the way is probably the most important thing. So in summary, you'll have some kind of baseline data. That might be stories too. It doesn't have to be numbers. It can be, you can put that on a run chart if it is numbers, or you could tell us stories. But you should be able to describe the changes your team have made, record your interventions, and really tell us how you feel about that. Did it motivate the staff? Do the team feel great? We certainly want to see a picture of every team in the presentations that you do at the end of the programme. And we'll also want to know what you're planning next, because we know that quality improvement, once you get the bug, that you really want to continue to do more things. So it's not just about your initial EQIP project, it's really about what you're going to do going forward. So the final presentation, when it comes, I want you to do that in 2 parts, and Merrick will tell you a bit more about that in the 10-minute presentation that you're going to do, and I've given you a little list of things that you can keep in here. You'll have a team display of a poster as well, or just simply your PowerPoint presentation slides put up on the wall for our World Cafe event. I put a few references in here, and the one from National Education Scotland, that third one in, has all these improvement tools we talked about at the event and I mentioned many times on the call. So if you need some ideas about which tools you can use and how that's going to help you display your data, you'll get it all there for free. It's an open resource. So thank you very much for listening to this first part, and I'm going to hand over to Merrick to really talk about continuous improvement and the lots of different places where you'll find your data that you can use and are already using as part of your EQIP pioneering work. Thank you very much.
Great, so thanks for that, Pat. And you may or may not remember me as the guy from Birmingham who commissions the National Clinical Audit and Patient Outcomes Programme, or certain project from it, and Epilepsy 12, which is the National Clinical Audit that you guys know is one of them. But I guess we thought it would be useful just to pick up what Pat's mentioned and then tie it around this measurement and data theme from a continuous improvement point of view, which I'll discuss briefly. And then, as Pat mentioned, I will also go through a final template for the celebration event, for the final event. So we have heard about quality improvement and specifically about, your iterative testing, designing, tackling the sort of messinesses on some of the things that you guys are working on within this collaborative. And I just wanted to highlight that this is really one facet of your continuous improvement journey. And we know that successful organizations, so if you look at the sort of Rubik's Cube below, there's different facets there. There's improvement, there's judgment, there's research, there's also quality assurance and a lot of other things there. But I think it all ties together, as you can see, so that although there's different colors, they're all part of the Rubik's Cube. And if you look over to the diagram, when we think about successful organizations, put it very simply, and I think I stole this from a junior doctor website, but very simply, they, organizations that have a culture around being successful in continuous improvement, they see research as what is possible, audit as what is actual in practice. So even though you think you might be doing well, let's have a look at some standards or criteria to see what actual practice is like. And then the quality improvement function is trying to make the research which is possible actual, or trying to really increase this testing phase and trying to improve outcomes, not only for patients but as a service as well. So from a national clinical audit point of view, we can really see how this is all tied in, and we assume that it's all tied in. And what we as commissioners hope is that you and your epilepsy services, and in fact patients and clinicians, receive some data. And yes, a lot of it is benchmarked data. Hopefully people trust it and upload it, and they can see a spread of their results in comparison to the rest. But benchmarking looking at benchmark data requires some action. So just like you guys are receiving some feedback in your quality improvement work in EQIP, likewise when you're submitting data, looking at your dashboards, and when you're then finally getting those reports, the benchmarking that comes out from that requires some action on your behalf. And this is where this, benchmarking is a verb. Benchmark is a noun, but what we're really hoping is that the benchmarking, the verb element, is this exploration and investigation of why a benchmark was achieved. And even if you're achieving really well and you don't see any need for improvement, I think the other services, they'll be coming to you and asking, what it is that you're doing that enables you to be benchmarking this top level, so to speak, for a certain process or outcome. So I guess what we see your role there is to share some learning with the others so they can also try and emulate and steal some of your ideas and improve. So how do we recognize continuous quality improvement? I really like this paper here that was written about 6 or 7 years ago, and a number of experts got together and tried to describe, if you looked at an organization, what are the fundamental elements for continuous quality improvement. And really they came up with 3 things, and that's systematic data-guided activities, iterative development and testing, and designing with local conditions in mind. So if you can have a look at this sort of bar chart, you can see the first thing, the systematic data-guided activities. Well, you've got that at your fingertips, which is Epilepsy 12. So you taking part in Epilepsy 12 will help you on your continuous improvement journey by, submitting data, reviewing it, and collecting it. We understand it's not easy. It does take time. But, it's just like money, putting money in the bank. The more you put in, hopefully, the more you get out. And this is what we hope that we as commissioners commission programs that RCPCH deliver, like Epilepsy 12, which enable you to get a lot from your data, but it does require collection. Also, what we're embedding and what we can see with the EQIP program here is that your iterative development and testing and designing with local conditions in mind, they're the 2 fundamental key things of the EQIP program, where you're working on your local quality improvement projects, seeking some feedback, testing, looking at the data, as Pat's mentioned in her webinar, capturing it, and then embedding it in a continuous process of, your plan, do, study, act cycle. And, for audit, it's all about action loops. Yes, it's not just collecting data once, letting it sit there and ticking a box. We really hope that potentially from prospective national clinical audit data, a lot of this quality improvement work will surface out and be stimulated by some of those results. But it does require your team to have this continuous improvement culture and to be supported particularly by your hospitals and your local QI and QA teams. So we hear about structure, process, and outcome, or process improvement and looking at resources. But there's one fundamental key thing that I think in order to get outcomes, whether positive or negative, culture is an important element and should not be removed. So in fact, structure plus process plus culture equals outcome. And although that's probably a very simplistic view of outcomes, whether they're service outcomes or patient outcomes, I think it's a fundamental point to realize that culture plays a huge element in the outcome. So, you know, if you're not partaking in Epilepsy 12, please do sign up, start recording some data, because it's, you know, what we're seeing is some great work happening in EQIP, and we're seeing this energy, and it'd be great if, you know, once and when the collaborative finishes, that you keep on going with your continuous improvement journey and keep on having measurement and data flowing. And the reason that's important is for two things. Number one, the CQC uses a lot of the national clinical audits in their inspections to grade services, as you know, and one of the low-hanging fruit where, you know, services and hospitals can say, oh, look, we are submitting data, we are focused on quality and improving quality and quality improvement, and that's by taking part in national clinical audits. So, you know, if you require improvement or you've been graded as not performing so well, taking part in national clinical audits will provide evidence for these inspectors from the CQC to then have something to say, actually, you know, you are submitting data, you are focusing on quality, and we can see that as evidence to help you move up to, you know, a good or an outstanding grading. So that's one element. But the other element, I think what's more important is for you guys to ask yourselves, you know, we've celebrated, we've done some QI work, but what next? You know, how do we know how good we are? We say we're very good, but what are our results showing? And taking part in the National Clinical Audit Program will help you with that. Do you know where you stand relative to the best? That's another fundamental question from a QI point of view. And hopefully when the results come out from Epilepsy 12, you'll be able to answer some of that. And also answer where variation may or may not exist, and what are some of the gaps that you need to think about as a team and potentially see where you lie in comparison with the rest, and maybe make some approaches, not just with your EQIP colleagues or other 11 teams that are in this collaborative, but you know, some hospitals around the country in England, Wales, or services around England, Wales, that might be doing quite well when some of the results come out. And you know, the key enablers here are the cultural elements, which is about leadership and governance. You know, it's about having the right resources in place and the right passion, and it's about the skills in your workforce. So we're hoping that by the time you guys as pioneers finish the EQIP program, you've got this skilled workforce, really passionate and focused on quality improvement. You've got the measurement element and data from Epilepsy 12, so that what's happening is you're synchronizing your audit and your quality improvement behaviors to improve your clinical care processes. So then, you know, when EQIP finishes, you are armed and ready not only to change care for the patients of today, but for the patients of tomorrow, and look ahead as to what may or may not need different approaches, you know, and it doesn't matter what quality improvement approach you take, because I know there's varied approaches across the NHS, but fundamentally it's that culture and also having an organizational focus and doing the same thing across the board, so that when you present at your committees, at your boards, at your divisional directorate meetings, you know, you're talking about the same stuff. This is how we do improvement. This is how we measure. This is what we've done. So that is really what I just wanted to highlight here from a commissioning point of view. You know, from a national commissioning point of view, how locally you guys can really embed a continuous improvement culture beyond the EQIP. And lastly, with Epilepsy 12, to plug it even more, you know, we just want to reassure you that what we're doing is trying to capture the patient voice and priorities, mix that with a national aspiration to provide data that looks back over time, but also is looking about doing more with data collection, so that over time, what you'll see is you'll have this fundamental tool where at any point in time, if some of your team members are looking for a QI project, or you've got rotating junior staff that, you know, need to do something in 3 or 6 months before their rotation finishes, what you're not doing is you're not reinventing the wheel, but looking at your national results and saying, look at that, this is something very clear that we could focus on. Would you mind taking this on board for your QI project or your audit project? So do watch this space, and we hope that, you know, you continue your QI journey by taking part in Epilepsy 12. So when the final event is confirmed, as Pat's mentioned, you will have a poster, and there's no reason why you can't cut and paste from your poster into this template that I'm going to talk you through. But what we're going to provide you with an opportunity and space is for all of you to be able to get up and describe to your fellow EQIP teams what you've shared and learned, what you were passionate about, some of the challenges, because it's not just about successes, as you may recall from our learning sessions. Sometimes it's just as valuable, if not more so, learning about the failures so that that's not repeated, and people can learn from, you know, mistakes or challenges and how they were approached, or just find out how not to do things and why you shouldn't persevere with doing certain things if they're not going to make a change to patient outcomes. So the next sort of 5 slides is a template that I'm just going to run you through. You can always refer to this recording if and when you come to, you know, piece it together, so to speak. And as always, you'll be able to log into QI Central, pull this off, and email the team if you have any questions. But I'll just quickly run through the next few slides. So there'll be a team title slide, and, you know, put your logo on here, put your team photo, list some team members, you know, make it as visual as you want it to. So this is your own personal space, you know, and if there's a certain photo or a certain thing you want to highlight here, it's just a title slide to really kickstart your 5-minute presentation. Then the next slide, or the next thing in your presentation, we'd like you to really highlight here what is it that you want to share with us. You know, out of all the things you've done in the last sort of 6 to 9 months in EQIP, here is the thing we want to share with you. So you can include, you know, once again, a photo or a driver diagram, whatever prompt you want to wish, or you just want to have a sentence here or a quote, and, you know, discuss it with everyone else in the room. So try not to stick up, you know, paragraphs of text, even though you've got one slide. You know, we see a lot of people putting minute, micro font text here, and they just read this out. We don't want that. You know, pictures are great, quotes are great, and, you know, I'm sure you as a team will fill in the blanks. And this is really, you know, it's formal to the extent where we're celebrating success. So, you know, we don't want well-rehearsed presentations. This is your opportunity to get out in front of everyone and say, this is what we really want to share with you. This is what we found. This is why we're excited. The next thing is sharing the data. So, you know, this is where, as Pat's mentioned, you can, you know, provide a run chart here. You can provide a graph. There might be some data collection that you've picked up along the way. There might be some qualitative data and feedback from patients. You may cut and paste from your poster or presentation template. It's completely up to you. But this is where, you know, we would really like you to back up some of the things you've learned or some of the results you've had with data. And that's the whole emphasis of this webinar, not only just for EQIP and the final presentation, but thereafter in your continuous improvement journey. You know, data and measurement are fundamental in you backing up statements or your patient saying, yes, this has been improved and the data shows how. So the second last slide, I think, is about engagement. And on here, we really want you to highlight and share with others how you've involved families or patients or any other stakeholders. That might be MDT members, different service lines within your epilepsy and seizure service, maybe a board member or an exec, or a patient focus group. Really just, you know, stick in here the different engagement that has happened with your project. And it's okay to talk about engagement as a team. You know, when we met back in Birmingham, I think it was in November, for the first learning session, a lot of you haven't met for the first time, and this was your only sort of protected time away from the sort of nuts and bolts of your daily life and clinics and clinical space, where you were able to meet each other and talk outside of that environment. So, you know, I am sure every one of the teams will be able to slot in something here and share with us as to what engagement has occurred. And then finally, you know, the lessons learned and advice to peers and your future plans. So, you know, on these last 6 months, if you were to give one bit of advice to any other epilepsy teams that might be going on to a future collaborative, or if there isn't a future collaborative, what is it that you want to share with people on their quality improvement journey, specifically in the work they do with children and young people in epilepsies and seizures? So likewise, apart just from that advice, you know, what are your future plans for quality improvement? So what happens next? What now? How are you going to take the learning from EQIP and focus on continuous improvement? What are your aims for continuous improvement? Do share that with everyone in the room, because it might be a nice way of other members from other teams picking up those highlights from you and then connecting and continuing connections even after the final event. And I know Mel and the team will communicate something after anyway, but this is a really good way of you know, showing and showcasing what you're thinking about in terms of the future. So as always, if you do have any specific questions about this webinar, just before I finish off, you know, you can always contact the RCPCH EQIP team. The email is there. Do log on to QI Central with this webinar. This recording and the templates will be up there. And I think I'm going to hand over now to Mel and the team with any questions.
Thank you, Merrick. I don't think we have any more questions at the moment. So if you do think of something later on, do please email the email address you can see on the screen, and then we'll be happy to answer those questions and to provide, even call and go through anything that you're concerned about, especially with obviously accessing your data on the Epilepsy 12 platform. Therefore, so we're going to probably end the webinar. I'd like to thank Merrick and Pat for the presentations that they showed today. And again, if you have any more questions, please do contact the team and we'll field them to Merrick and Pat for them to answer. Thank you again for your time.
Thanks, everyone.
Thanks, everyone, and keep on improving. It's fantastic to see.
Thank you. Bye.